Good morning. We're going to be getting started now. Welcome to those in the room and welcome to those who are attending by webinar. My name is Dr. Bonnie Sunday. I am a practicing primary care physician with a practice in Elma, New York, and also a part-time medical director here at Blue Cross and Blue Shield. Today we're going to be talking about documentation and coding, and just a few housekeeping tips. If there are any questions from people participating via webinar, they can be submitted through the chat function. And those who are in person, please write down your questions on a piece of paper, and we will be circulating around and collecting those questions and answering them at the end of the presentation. For those who are attending via webinar, the lines will be muted during the presentation. And participation here is eligible for CME credit. The form and evaluations will be emailed after the event. So I'd like to introduce Carol Olson. She's the Vice President of Quality, Education, and Consulting Services at Altegra Health. She's a certified trainer with the AHIMA Academy for Icd-10, and she's also designed and conducted provider coding, documentation, and compliance training for thousands of providers nationwide as a certified clinical documentation specialist. Welcome, Carol.
Thank you. So a few acronyms to be familiar with, MRA, Medicare Risk Adjustment, and HCC. How many of you heard of hierarchy condition categories? So hierarchy condition categories are they take similar diseases with similar costs and they put them in the same bucket. So they're really looking to see for 2014 how much resources will we need to take care of the patient's conditions for 2015. So it's always perspective. We're looking now to see how much resources will we need, and it's all based by the Icd-10 codes. MA is Medicare Advantage, so that's the Medicare Advantage plan that works under this risk model. And the RAF score is the risk adjustment factor that determines how much per member per month the health plan. Adjustment is a method used to adjust payment based on the health status and then demographic characteristics of the patient. So in the past, the demographics was really, how old is the patient, where does the patient live, was really what it was based off of. And we still have a small portion of that is based off of the demographics. But after that comes all their chronic conditions. And on January 1st, the slate wipes clean. So on January 1st, all we have are the demographics. And then as the patients come in for what we call an approved face-to-face visit with an approved provider type, so an MD, PA, NP, DO, there's a whole long list of the provider types. Mainly what are not on there are your RNs, LVNs, and MAs. But most of your professional provider types are on there. Once they come in and we document their conditions and we report them with codes, then the RAF score starts adding up. I have a slide to show you a little bit about that in just a little bit. So it basically adjusts the payments for the population, which is really a good thing because years ago, you might have a sicker population than someone else, and the revenue was kind of the same. And so now it's pretty much leveled the playing field as far as making sure we have the right resources for all the different, whether you have a sicker population or a healthy population, the right resources should be coming in to take care of them. So it is, basically it's kind of, if we started here in 2007, the model was 100% implemented on this risk for Medicare. And they, take away money from the healthy population to give more to the sicker population. But if we're not reflecting how sick our population is, then we're not getting the right resources coming in. And it is prospective, so we're looking again, like I said, the 2013 dates of service, so whatever was coded in 2013 impacts 2014 payment year. And 2014 payment year will impact 2015 payment year. And some things are additive, so if you have like diabetes and congestive heart failure and COPD, they're additive, and other things are in a hierarchy. So like diabetic complications are in a hierarchy. Cancer, if you have a primary and a secondary, they're in a hierarchy. But really all we need to do if you're a provider is accurately reflect the health status of your patients, and everything else will fall in line. So the medical record should chronologically document the care of the patient, and it is an important element contributing to high quality of care. The progress note should update the patient's clinical course of treatment and summarize the assessment. So we're talking about a good SOAP note. We know you do the work. We know you ask the questions, but sometimes in your busy day, something might not get written down. But remember, not only for diagnostic coding, but for your E&M levels as well. The medical decision-making that you do every day, and sometimes don't give yourself enough credit for it, you're thinking about different meds and is there contraindication, and a lot of different things that go through the thought process may not make its way to paper. And unless it's on that document, if we get audited, we can't prove that you actually did it. So for not only for risk purposes, but also for your E&M levels, it's important to really put down what you're thinking and the full picture of health. So the role has changed over the years. I've been in the medical field for close to 30 years, and it's when I saw what I first started working, the providers would just write, a sentence or two, a small paragraph to kind of trump their memory from one visit to the next. But in today's world, the record is used for so many other purposes, and we really have to reflect everything. So it's not so much that you have to have a large quantity, it's the quality of what gets put in the medical record. So the spoken word perishes, the written word remains. We want to make sure that, we write down our thought process and what we're thinking. Documenting and coding the patient's diagnosis to the highest level of specificity in the medical record, it drives the development of care management opportunities, case management opportunities, and helps us determine which patients are in the most need of resources. It shapes the coordination of care in both the inpatient and outpatient setting. And clinical documentation and coding are the means for communicating the patient's medical record to both specialty, health plans, and CMS. So data is used for many, many purposes. And, today's world, we have all kinds of analytics and all kinds of, health grades and leapfrogs and all these areas that you can go in and you can see, how well a provider is doing in a certain area. And remember, if our patients look really healthy on codes in paper, but they're in and out of the hospital and on a lot of, medications and things that don't equal out, then it doesn't really give us the true picture. It looks like maybe we're not doing what we should be doing. So we want to make sure we have a sicker patient. We even have codes now for noncompliance. And those are good codes because we have patients, you're doing your job, you're doing your work, you're telling the patient what to do, but the patient's noncompliant. You have codes for that to help show, I'm doing my part, but the patient's not doing their part. So we have a lot of ways of communicating, the total situation. So affects the accuracy of your patient's health status and is reflected in your measures and patient outcomes, which are things that are all being measured in today's world. Reflects CMS assessment of the quality of care delivered and drives government distribution of funding to support enriched Medicare Advantage patient services, and not just Medicare Advantage. So how the model works now is, and this is a good slide to kind of give you an idea, just an idea of how that RAF score works. This slide is divided into thirds. So if you look on the left side, all the codes, all the conditions were documented and coded appropriately. If you look in the middle column, there was poor specificity, and on the right side, the chronic conditions weren't documented. So maybe that patient came in for an acute condition, and we're not saying you have to document everything that's wrong with the patient every time they come in. That's just not possible. But at least once a year, and preferably twice, once in the first 6 months and once in the second. And especially if you have a patient that's non-compliant and doesn't come in, and maybe they fell or there's an acute episode and they're there today, that would be your opportunity to document their chronic conditions. So if you look at this, the top two rows, that's the demographic piece. A 76-year-old female, Medicare, Medicaid. The RAF scores are identical all the way across. It doesn't matter how you document. And that score remains every January 1st. So that stays in there, whether that patient comes in or not, those scores stay there. Now, the third row down is where we get into their chronic conditions. So last year, the model had 5 categories for diabetic hierarchy. This year, there's 3. So you either have no complications, you have a chronic complication, or you have an acute complication. So those are the 3 categories for diabetes. So diabetes, seems to be the area that we can make the biggest improvement because of the fact that we see a lot of uncomplicated diabetes being coded when, in fact, the patient does have complications. So if you look here on the left side, the diabetes with a chronic complication. It doesn't matter which one now. It used to matter if it was renal or circulatory or which one. We always want to document all of their complications. So if they have diabetic CKD and they have diabetic peripheral neuropathy and they have diabetic retinopathy, we would want to code all of those. The first code, the 250, whether it's a 40, 50, 60, depending on the complication, all has the same weighted score this year. So you'll see it's a 0.368. But if you, in the middle column, we just coded diabetes unspecified, 25000, and that has a RAF score of 0.118. So there's a big difference between whether they have a complication or they don't have a complication. And resources needed it's also a big difference, right? Because we need a lot more resources if patients have complications, and diabetic ulcer, whatever it might be, more resources are going to be spent for those patients. And in the last column, the diabetes was not coded at all. And remember, diabetes, like I said, you don't have to code every condition every time the patient comes in, but diabetes pretty much impacts a lot of different things, whether it's a medication you're giving, whether it's, a wound, or whether it's a, fracture, whatever it might be, can slow the healing process. And if coding guidelines tell us if it impacted your care, if it entered your mind and your thought process, then we can code it. So we want to make sure we document it and we code it if it did impact that episode of care. The next row down is congestive heart failure, which was only documented in the first section here. And that's pretty important because that is a chronic condition, again, that can impact a lot of things. And Medicare says we realize that when you have certain conditions along with other conditions, there's going to be more resources attached to it. So they not only gave us a RAF score for the diabetes, they gave us a RAF score for the congestive heart failure, they also gave us something called an interaction code, which the interaction means you have the two conditions together, and they give us an additional RAF score for that. You don't have to worry about any of this. As long as you're documenting everything and coding, it's all done in the background. So it doesn't have to be in the same episode. It just has to be within the same calendar year that those codes get reported. And remember, codes are coming from a lot of different sources, right? They're coming from inpatient, outpatient, primary care, consultants. They're coming from multiple sources. And then in the next two columns, they did not code the CHF, so we missed out on that interaction. So all of these columns would be added up and multiplied out by a factor, and that determines how much the health plan would receive in order to take care of the patient's medical needs and to physician contracts and so forth. With all that said, there is a process called RADV, and not just for Medicare, but there's always audits. There's always audits that want to say, if we paid you for something, we want to make sure that it was paid correctly. So a RADV is risk adjustment data validation, where they're saying, okay, these are the codes you submitted. They select 201 members. These are the codes that you submitted for the calendar year. Now show me one record that shows, supports the codes that were submitted. For instance, if there's 4 codes, say that 4 HCC categories that were submitted, we can use one record that has all 4, or we can do one record for each one. So sometimes if you have a physical, one record might be all 4. We can submit that. But if there's a really good record for diabetes, we submit that one. If there's a really good record for congestive heart failure, we submit that one. And that's how they get, Medicare would go ahead and review them, determine that there was all those official coding guidelines were and documentation guidelines were followed, and we either pass or we fail. Billing codes without appropriate supporting documentation is a compliance risk and could also create a risk for investigation and fraud. There's so much analytics today. There's so many ways that things can be drilled down. And if, for instance, an inpatient diagnosis that you probably rarely would ever see in the outpatient setting, if they get coded in the outpatient setting, they can really pick up on that really quickly. And they can see there's some problems here. So they can drill down and say, well, how many times was that code submitted? So, we also, in addition to making sure we're coding everything, if we find that we're coding something incorrectly, which happens, sometimes the EMRs have the wrong codes in the system. There are, I don't consider that fraud. That's just, we see that sometimes there's issues, and we can correct these things. So we can go back and say, and pull those codes out and resubmit them. So we would also not only want to know, we want to add the codes that were, not put in, but we also want to take away things that were put in incorrectly. So thoroughly reviewing documentation and coding practice through internal audits is important. We want to make sure that we are coding accurately and that we have the right supported documentation. Now, this key statement is really where I find to be the biggest error, is that the highest degree of specificity refers to assigning the most precise ICD-9 code that matches the narrative description within the medical record. And that's where sometimes, it says DM, but we're coding diabetic renal. Or it says, depression, but we coded major depression. 2 different ICD-9 codes, totally different values. One has a much higher value than the other. If we say hepatitis and we don't say chronic hepatitis, there's a different code, different values. So we have to be really careful that our coding matches the documentation within the medical record. In addition to that there's a requirement of the signatures. So regardless of what you document in your medical record, if you don't sign your record and you don't have your credential, your MD after your name, NP, PA, whatever it might be, we can't use that documentation because Medicare requires that it's by an approved provider type, and they can't determine that unless you have your signature and your credential after your name. So be really careful that we have your signature and your name. In addition to the patient's name, and they state in their manual that the patient's name should be on every page of the document, patient name and date of service. The manual states that we would like to see that. Sometimes we'll see page 1 of 3, 2 of 3. We'll see the continuity, but ideally a patient name and date of service should be on every page. It should be complete and legible and standalone. Support the diagnoses and standalone. And what I mean by standalone is that in the outpatient setting, we can only submit one date of service per ICD-9 code or HCC category. So if you say they had a stroke a month ago and now we just see the hemiplegia, we don't see that it's a late effect of the stroke. And within that record, we could only submit the code for the hemiplegia. We couldn't submit the code for the late effect of stroke. We can't combine two records into one. In the inpatient setting, they use the whole length of stay. So from admit to discharge and everything in between, so it becomes a lot easier sometimes in the inpatient record to support diagnoses such as that. But in the outpatient setting, it's, the guidelines are one date of service, and it has to stand alone. If you're using an electronic health record, make sure you have the electronic verbiage. And this was really problematic a few years back. We're really not finding as many problems in today's world as we did a few years ago. It should say electronically signed, approved by, verified by, signed by. One of those statements should be in there. We should be able to tell it's an electronic medical record, and usually you can because it'll say have that verbiage and also have a date and time stamp. Sometimes what we're finding are there's just almost like a Word document where it looks like it's an electronic medical record, but there is no date and time stamp. So we should be seeing, a true EMR usually has a date and time stamp to recognize that. So the complete picture of health. We really are asking that you paint a picture of the patient's severity with your words in order for the coder or yourself, if you're the one doing the coding, to paint that same picture with the diagnostic codes capturing severity of illness and resource utilization. It's getting the right resources in and knowing which patients are in most need of resources and treatment, care management opportunities, keeping them healthy, keeping them out of the hospital. That's what this program's all about, is making sure we're proactive, and we're not waiting until there's an episode. We're trying to keep that patient healthy. If it wasn't documented, we know it can't be coded. And if it can't be read, it can't be coded, and that's where the EMRs have become very helpful. If it isn't coded, it can't be captured as data, and that's really what ICD-9 coding is all about. It started as morbidity, mortality. We're still looking at, risk along with our ICD-9 codes. If it's supported in the chart but didn't make it to the claim. So sometimes these are issues that we're finding that, the doctor's doing a great job. They're putting everything in their record. They put all these codes on the record. It goes to the front office. The front office says, oh, we're only going to put 4 codes in. And then it goes to the biller, and the biller says we only really need 1 or 2. Everybody not understanding the importance of this, and that reflecting the whole health picture. So if codes drop off along the way, and these were codes that have risk attached to them, that's a problem. So making sure, if you have any kind of issues around your data through your clearinghouse or your billing company, or that you can't submit more than 4, that's something, to bring up. The official coding guidelines, as I mentioned earlier, come out on October 1st, and I've given you the websites for both the ICD-9 guidelines and the ICD-10 guidelines. It's kind of a good thing to take a look at the ICD-10 to see what's changed, what's different from I-9. There are some differences. There are some things that are different. The old MI or the MIs, used to be 8 weeks. It's now going to be 4 weeks. So these are things that you're going to need to start documenting a little bit differently from what you have. So, when you say status post-MI, how do we know how many weeks that was, or recent MI? As a coder, we code it whether it's less than 8 weeks or more than 8 weeks with symptoms, or an old MI, which is, a 412. In I-10, it's going to be 4 weeks, not 8 weeks. So now's a good time to start documenting that. Laterality, a lot of things, and Dr. Sundry is going to address some I-10 issues. But you can go in and you can look to see what's different. Clinic is our official coding guidelines. It's part of the 4 cooperating parties that put together the official coding guidelines. And Coding Clinic goes way, way back, many, many years, and there's sometimes still old coding clinics that are still relevant. So even though the date might be old, this one's actually 2012, so it's not that old, but some of them are a lot older, but they're still valid. And it's built off the guidelines that are in the front of our book. American Hospital Association puts it out, and it's not a free resource. You have to pay for it, so a lot of people don't have access to it. So I'd like to kind of give you some of the coding clinics that I think are, a little bit maybe something that you might not be aware of. So you can write in and you can ask questions, and they answer the questions. So I have a few that I'm going to cover for you. Since our facility has converted to an electronic health record, providers have the capability to list the ICD-9 code, diagnostic code, instead of their written description. Is there an official policy or guidance requiring the provider to record a written diagnosis in lieu of an ICD-9? I just did an audit the other day, and this particular provider, it was a handwritten note, wrote in codes. So 401.1, he had 272.2, all of it was in codes, and he had all the treatment, everything that the provider needed to put on that record was there, but they never gave me the diagnostic written description. They never said hypertension. They never said hyperlipidemia. They never said diabetes. They just wrote the hemoglobin A1C, and as coders, we're not allowed to be clinical, and we're not allowed to code from codes. And we used to tell providers this, and they'd say, well, show me a document that says I can't. Well, somebody must have wrote this in, and there's a long, response here, but mainly I'm going to read this one. So this particular one I thought was a little interesting because to me, borderline is kind of like a probable or suspected, right? So in this coding clinic, they say coders are confused as to the correct coding of a borderline diagnosis. The advice published in Coding Clinic appears to be contradictory. The advice instructs coders to code 416.8, which is borderline pulmonary hypertension, as if it was confirmed. However, a diagnosis of borderline diabetes, it directs us to 790.20, which is an abnormal glucose level. So why would you code a condition for one thing and not the other when the treatment was borderline? when you look up your codes in your alphabetical index, and you go to diabetes, and you scroll down to the sub-classifications, there's a sub-entry for borderline, and that takes you to the abnormal glucose. But when you go to pulmonary hypertension, there is no sub-classification for borderline. So they're telling us, they're instructing us, and this is the coding clinic, which is an official coding guideline, that when you go to the index entry and there is no borderline indentation, then you code that condition as if it existed. When I first read this, I thought, wow, that to me seems like a borderline condition. Why would I do that? So I like to bring that to everyone's attention, that, borderline for some things will get coded. But if you say probable, suspected, and consistent with, and those types of verbiage, we will not be coding them. What is the code assignment for depression and anxiety? Now, this particular one paid special attention to the word and. It doesn't say with, it says and. Because with makes causal relationships in a lot of instances, but the word and means I have diabetes and neuropathy. They're coding them totally separate. I have depression and anxiety. But in our indexing in our book, it used to be that if you looked up depression or anxiety, and it would say, it would then indentate with, you also have the other one, you have depression and anxiety along with it, it would always take you to dysthymic disorders, 300.4. But they're telling us now in this coding clinic that you would only assign the 311, so that's depression NOS, and then you'd code the anxiety NOS unless the provider makes that established linkage, such as using the word with. So if this said depression with anxiety, you'd be coding the combination code for 300.4. But because they use the word and, you're coding them separately. So sometimes this makes a difference in the values. So we want to make sure, and that is a little odd, so that's why I wanted to put that in there for you. Here's where they expanded the codes out all the way to a body mass index of 70 or greater. And at the bottom, you'll see there's the morbid obesity code. So we want to say the word, we want to say the clinical significance first. The BMI supports that. That is part of the meat that we're looking for. Older coding clinic. And this one is interesting because in ICD-9, in ICD-10, they've taken care of a lot of the issues that we have. But in ICD-9, we had a code for personal history of leukemia. We also had a code for personal history of alcoholism. Well, why would you use a personal history of alcoholism when we have a code for alcoholism in remission? It seems a little odd. And in Icd-10, they've taken care of that. In this particular question, they're asking, with the new fifth digit, so this was back in 92, when they came out with the codes for leukemia in remission, when would it be appropriate to code from V10.6, personal history of leukemia? And they're basically telling us that the only time you would code the personal history of leukemia is if the provider told us the patient was completely cured. Otherwise, we're using leukemia or leukemia in remission based on the documentation. So, these are situations where, I think in I-10 it's going to be a lot clearer. The other one is evidence of. So we know we don't code probable, suspected, consistent with, but here's they're asking, can you code evidence of cerebral atrophy? And the main answer here is that the word appears to be, or consistent with, or these are part of the outpatient guidelines that state we cannot code any probable or suspected conditions. But the word evidence of a particular condition is not considered an uncertain diagnosis and should be coded and reported in the outpatient setting. So evidence of, we would code. Consistent with, probable, suspected, we would not. So just be aware of that. Really what we're looking for monitoring of all the conditions that we are going to document and code in that episode of care. The medical record should document them and show that evaluation. And it doesn't have to be long and lengthy. It just has to show some kind of statement. So whether it's, hypertension, stable on lisinopril, diabetes, hemoglobin A1C was, 6.5, continue metformin. We just want to see how did it impact care. Did you address these things? If it says, if it just all we have is a list of diagnoses in the assessment and nothing about them, we can't code them. Or if they're just in the past medical history and we don't, like I see past medical history, atrial fib. Regular rate and rhythm today, I don't see any anticoagulation. How do I know they still have atrial fib? We have to see management of it. So we're looking for, some verbiage that says stable on meds, getting worse, you're ordering tests, maybe you're ordering a lipid panel, conditions improving. Be careful of the word resolved. Resolving, improving, we can still code. But once you say it's resolved, that's a follow-up visit. We are not coding the condition again. So think about pediatrics and otitis media. It's resolving, we're coding it. But when you say it's resolved, now we are coding the V code for follow-up visit because they no longer have the otitis media. So those V codes come in handy. Showing your medical necessity means you're justifying your treatment choices. And again, supporting your E&M levels. So it's very important that you show the work that you're doing, and like I said, so many times you take for granted because your thought process is going, your wheels are turning, I can't give this med because of this condition and that. It may not make its way to paper, but making its way to paper is going to help you with your E&M levels and also show the Here are some examples of monitoring. Patient with hyperlipidemia, you're ordering a lipid profile. Patient with osteoporosis, maybe you're ordering a DEXA scan. Take note of the aneurysm. If we just see that in the past medical history or we see aneurysm in the assessment, was it repaired? Are you monitoring it? What was the size? When's the next ultrasound? We want to see that it's still a current condition. Sometimes things are repaired and they no longer have those conditions. It becomes a history of an aneurysm. So be careful of that. Any kind of lab or x-rays. You guys do a great job. So a lot of times it's initialed and dated and patient-informed, but unless you bring that into your progress note for that date, we can't code it because Medicare realizes that a lot of times when we're ordering tests, we're ordering maybe what we're screening for, and so it gets coded as maybe, pneumonia on a chest x-ray, and then it comes back and they don't have pneumonia. So what we want is, like, if you see COPD or atrial fib on an atrial fib document on this EKG, bring it forward into that progress note and say patient has a new diagnosis of atrial fib, we'll start anticoagulation or whatever we're going to do for it. It needs to be brought forward. Chest x-ray reveals COPD, again, bringing it forward into your record. And then there's diagnoses like hyperlipidemia, DJD, depression, GERD, things that sometimes we just, we see them in there, we know they're on a med for it, but we don't really show the monitoring of it. So we want to know, is it if I see DJD and I see the exam, everything's normal, there's no pain, there's no swelling, I don't think anything about it, all I see is DJD in the assessment, we need to know. Same thing with neuropathy. Did we do any kind of testing on that? Do they have any, decreased pulses? We want to see some kind of management and see how it is. Is it getting worse? Is it getting better? Treatment. So, patient with hyperlipidemia, counseled on diet and exercise. It doesn't have to be a prescription drug. So, you can just, like osteopenia, recommend calcium and vitamin D. And these are just some examples. So problem listen, as we have since we have the ability of the EMR system, take note that both the OIG and CMS have been watching these carefully and looking for what can be cloned or blown in from one data service to the next. So we know they're very helpful. They help us quite a bit. But if we're blowing in information that is identical, and a lot of times, it'll say something's resolved, but the note reflects that it's not resolved. Or, because it's information that's getting blown in. Or they have, a condition, sometimes the problem list will have acute bronchitis and chronic bronchitis and CKD stage 1 and stage 3 and end stage all within that same, it's a list of things that never gets cleaned up. So they don't want us to cut from them. They want us to see, in the assessment, actually the easiest way of doing it is coming down into your assessment, giving us a sentence or two about each diagnosis. It's really clear. It's really concise. Any auditor auditing your record can see that you address that situation, and, it really will. That is the best way to do it. Because the problem list and past medical history, sometimes they say active chronic problem list, they're just lists, and we really don't code from them unless we see the evaluation. So the best practice is if there is no support in the current note for the condition, it should not be coded. We're looking for that support. If you're using any kind of paper record, be careful of approved abbreviations. An arrow up and arrow down is not an approved abbreviation, and there's a coding clinic specifically to this. So if we see arrow up lipids or arrow up cholesterol, we cannot code from that. The documentation, again, a lot of times we see hyperlipidemia or hypercholesterol, but without the meat. We want to know, are they on a statin? Did you advise low-fat diet? What are we doing for their for the condition? So again, the records are coming from multiple sources, and we want to bring them forward into our progress notes at least once a year. So make sure, even we're not allowed to code from the labs and the radiology, so be careful of that. The late effect of stroke. This code here, this 436, used to be the code for stroke. We see this quite frequently, and the OIG, we've seen it in the national samples and the OIG audits. They have targeted this code. It is no longer the code for stroke, and it is, there's only really two ways that we code a stroke in the outpatient setting, because strokes are usually coded, the acute strokes are usually coded in the hospital. So when they're coming back to you post-stroke, we either code the history of stroke, meaning they have no residuals, or we code whatever the residuals are, hemiplegia, hemiparesis, dysphagia, whatever it might be, we code them as a late effect. When you look up the code, you go to the word late effect of cerebral vascular disease, and it lists all the complications, a lot of complications that are typical of a stroke. They start with the rubric 438, and in this particular instance, it breaks down to 438 is the late effect of cerebral vascular disease, and if it's hemiplegia, it'd be 438.2, and the 0 means that you didn't tell me the effective side. Now, be aware that in ICD-10, it's going to default for you. So we really need to know, are you right-handed or left-handed? I fractured my wrist, and I can tell you when it's your dominant hand, this is my dominant hand, it's really debilitating. You can't do things, but all the things that you do with your right hand, all of a sudden you can't do. So if it's a right-sided stroke and I'm right-handed, I'm going to need a little bit more physical therapy. You're going to need some more care. So we really want to know now, is it a right-sided stroke, but are they right dominant? That's really what we need to know, because in I-10 it's going to default for you if you don't put that down. So be careful of that code. Remember, the V12, the V1254 for late effect of stroke, for personal history of stroke, meaning they have no residuals, or the late effect. Now, a common one we see is right-sided or left-sided weakness, right? There is no code listing for that. So what you would do to code that is you code 43889, other specified late effect of stroke, 43889, and that could be any other late effect of stroke that's not one of the ones listed. And then because we don't know what that is, because it just says other, you have to code what that is. You code the right leg weakness or leg weakness in addition to that. Or if it was urinary incontinence, you'd code the urinary incontinence in addition to it to say what that late effect is. So if it's not one of the ones that you can index, you can code the 43889 and then add the second code for what that is. Now, COPD, asthma, emphysema, all the overlapping conditions, they overlap, and it depends on whether it's with asthma or emphysema, if it's exacerbated or asthmaticus and so forth. Be really careful where they overlap. The 496 code is really only used when all we have is COPD. But if it's exacerbated or if it's with or without chronic bronchitis or asthma, they're coded differently. Really affects the revenue is the 493.90 asthma unspecified versus the 493.2 for chronic obstructive asthma. The 493.90 does not risk adjust. So if you know that it's chronic obstructive asthma, we would like you to code it to the highest specificity. It also excludes the acute bronchitis or chronic obstructive bronchitis, so you would code those in addition if you had the asthma as well as the acute bronchitis or chronic obstructive bronchitis. So here's the unspecified codes that we only code if that's all we know. And I threw this slide in here because I hear from providers all the time, that's not how we talk. The way the codes are in the books is really not current to our current terminology, medical terminology that we use today. And that's another reason why we're going to I-10, because it's so outdated. And I just wanted to show you on this slide that the terminology that you use, mild intermittent, asthma or moderate persistent, that is an I-10, but it's not an I-9. So this is just kind of showing you how we're going from I-9 to I-10 with a better terminology, clinical terminology. Our fifth digit is going to tell you whether it's unspecified with status asthmaticus or with acute exacerbation. So again, we do not code from just signs and symptoms. If I see the wheezing and that they're getting worse, I can't say they're exacerbated. The provider has to actually say that in their documentation. The other thing to note on this slide is that if you have a fifth digit of 1 and a fifth digit of 2, meaning one is asthmaticus and the other exacerbation, the coding rule says the asthmaticus supersedes the exacerbation, and you would code the fifth digit of 1. There's combo codes at the bottom of the slide. Combo codes are used whenever we have the two conditions together, so asthma and COPD or asthma with allergic rhinitis. We see that frequently coded, separately, but there is a combo code. And the rules around combo coding is that you code only the combo code if it describes all the elements. But the minute we're leaving something out, like in that leg weakness situation, then you have to add a code until all the elements are described. So if I say you have hypertensive heart disease, and I don't tell you, and I say it's CHF, CHF, then I have to add that CHF because it's not giving me the full description. So diabetes, as I mentioned earlier, is probably the quickest way to improve our documentation because we see so much uncomplicated diabetes. Nearly 26 million children and adults in the United States have diabetes, and 79% have prediabetes. And quite a few are still out there that haven't been diagnosed yet. And as many as 1 in 3 Americans will have diabetes by 2050 if we continue in the method that we are right now, the trends. $245 billion per year are spent. And again, patients are always getting their care. They get their dialysis, they're getting their care. The only way the right resources come in to take care of those needs is by coding them correctly and documenting them correctly. So what do we need to know to code diabetes? Clinically, it's nice to know, are they type 1 or type 2? Are they controlled or uncontrolled? But the most important revenue driver is, do they have any complications, and which ones do they have? So that is the actual type 1 or type 2, controlled or uncontrolled, has no bearing on the model. It's whether they have complications. Here's a list of some of the complications, the renal, ophthalmic, neurologic, and they used to be in a hierarchy based on the different types, but remember this year they changed that, and it's only whether you have uncomplicated diabetes, you have diabetes with a chronic complication, or an acute, same values. And the fourth digit, is a driving factor, and the fifth digit tells us whether they're type 1, type 2, controlled, or uncontrolled. Here's a kind of estimated cost of care for different complications of diabetes. And you can see it's quite different. So we do want to know when they have a complication versus an uncomplicated diabetic case. And the most important thing with diabetes, in addition to getting their complications, is making the causal relationship. In order to code diabetes, if we see diabetes on one line, neuropathy on the other, you can have neuropathy and not be a diabetic. So we have different codes for whether it's neuropathy not in diabetes or neuropathy in diabetes. And the only way we can code it as a relationship is if you say due to, caused by, secondary to, or the easiest way to do it is just say diabetic CKD, diabetic neuropathy, diabetic retinopathy. Less to type, less to write, very concise, very specific, and no auditor can question that you did make a causal relationship. Remember, if you say diabetes and neuropathy, we can't code that as a causal relationship. The word and does not make it. So be careful of that. Here's the common paired codes. And most importantly for 2014 is that you must code the stage of CKD. We used to get away with just coding the 585.9 and unspecified stage of CKD, but now only stage 4 or higher risk adjust. So they've done away. We're still getting like a little bit of weight on the lower ones until, for a little bit longer. They're paying 25% on the lower ones and 75% on the newer ones. So still always want to code the stage. If you know it, try not to give us that unspecified stage. Let us know, is it stage 1, 2, 3, 4, 5, or end stage. There are 3 conditions that do not require a causal relationship, and that's hypoglycemia, osteomyelitis, and gangrene. We always code these due to diabetes, regardless how you document them, unless you tell us it's not due to their diabetes. Then we would not code them as a diabetic complication. So ulcers of the lower extremities, particularly the feet, are common in diabetics. But they could be due to many things. So they can be due to diabetic neuropathy, diabetic PVD. Be as clear as possible of if we know what they're due to, and make that relationship due to diabetes or a diabetic ulcer. And be careful of the word wound. Wounds do not risk adjust. So if it is truly a wound, we're going to code it as a wound. But if it's a diabetic ulcer, we want to call it that. And these are the stages of the ulcers, and the 2 at the bottom, the bolded ones, are the ones that now fall in the model. So definitely if they're stage 3 or 4, we would want to make sure these are documented. We would be missing the values. And these are the stages of the ulcers, and the 2 at the bottom, the bolded ones, are the ones that now fall in the model. So definitely if they're stage 3 or 4, we would want to make sure these are documented. We would be missing the values. Now, secondary diabetes works just like primary. However, they're not type 1 or type 2. They're due to a condition or an event. So you either had your pancreas removed and you're no longer producing insulin, or maybe you've been on chemo or steroid use and you've become, type 2 diabetic, or you become diabetic. So they're not type 1, type 2. The 5th digit's only going to tell us whether they're controlled or uncontrolled. So instead of 250 rubric, it's 249. The 4th digits are identical, 4 for renal, 5 for ophthalmic, and so forth. The 5th digit now is only going to tell us if they're controlled or uncontrolled. So, and again, you need to let us know. And if there's some rules around, if they have their pancreas removed, we have to code the absence of the pancreas, along with the fact that they are not producing the insulin and the 249. So there's 3 codes that we would use. You're really going to love I-10. And Dr. Sunday talks to you about it, because they've taken a lot of these conditions that we have to code 2, 3, 4 codes, and we only have to code 1. They put them into combo codes, so it's a lot better. Okay. So the other area that we see as being problematic is the cancer coding. So diabetes is a great area to start with, and then the cancer coding, because there's high values of money coming in. If we say they have an active cancer, we're going to get paid for that code. If we say a history of cancer, we're not going to get paid for that. So we want to make sure that we're accurate. So sometimes what we see is history of breast cancer in the opening statement. You get down in the assessment and it says breast cancer. There's nothing else about the cancer. And guess what gets coded? Active breast cancer. We are not allowed to code that per the guidelines. The guidelines state when a primary malignancy has been eradicated or removed from its site and there's no further treatment to that site, we can no longer code the active cancer. That's immediately come back post-op. That's a V code for history of breast cancer. But if that same patient has breast cancer, has it removed, and now we put them on chemo, radiation, or antineoplastic treatment, we can code it as an active cancer until the treatment stops. Well, the only way we know if the treatment stops is if it's documented. So we need to know status post-mastectomy, on chemo, or finished chemo last month. No evidence of disease, NED, we'll continue to monitor. Now we know it's a history of cancer. Prostate cancer is probably the biggest problem that we have, because we sometimes don't get told whether or not the prostate's been removed. So we monitor PSAs, we have V codes for those conditions. You know, we want extra mammograms, extra PSAs. That's what the V codes are for. But if their prostate hasn't been removed, let's say they're an elderly man that refuses surgical treatment, he still has prostate cancer. We don't have to see treatment for that, right? He still has it. It's when it's been removed that now we need to see active treatment. So once it's been removed, tell us the status. You know, are they on treatment? When did the treatment stop? You know, so we know whether or not, or they refuse treatment and they still have active cancer. Okay. So the other area that we see as being problematic is the cancer coding. So diabetes is a great area to start with, and then the cancer coding, because there's high values of money coming in. If we say they have an active cancer, we're going to get paid for that code. If we say a history of cancer, we're not going to get paid for that. So we want to make sure that we're accurate. So sometimes what we see is history of breast cancer in the opening statement. You get down in the assessment and it says breast cancer. There's nothing else about the cancer. And guess what gets coded? Active breast cancer. We are not allowed to code that per the guidelines. The guidelines state when a primary malignancy has been eradicated or removed from its site and there's no further treatment to that site, we can no longer code the active cancer. That's immediately come back post-op. That's a V code for history of breast cancer. But if that same patient has breast cancer, has it removed, and now we put them on chemo, radiation, or antineoplastic treatment, we can code it as an active cancer until the treatment stops. Well, the only way we know if the treatment stops is if it's documented. So we need to know status post-mastectomy, you know, on chemo, or finished chemo last month. You know, no evidence of disease, NED, we'll continue to monitor. Now we know it's a history of cancer. Prostate cancer is probably the biggest problem that we have because we sometimes don't get told whether or not the prostate's been removed. So we monitor PSAs. We have V codes for those conditions. You know, we want extra mammograms, extra PSAs. That's what the V codes are for. But if their prostate hasn't been removed, let's say they're an elderly man that refuses surgical treatment, he still has prostate cancer. We don't have to see treatment for that, right? He still has it. It's when it's been removed that now we need to see active treatment. So once it's been removed, tell us the status. You know, are they on treatment? When did the treatment stop? You know, so we know whether or not, or they refuse treatment and they still have active cancer. So it's important not only to give us a status, but also let us know if they have any metastasis. So did it go to any other areas? Because there's a hierarchy. That secondary cancer is a higher weighted code than the primary. Okay. And if we don't know a primary or a secondary site, we actually have a code 199.1 for an unknown primary or secondary site. Now, protein-calorie malnutrition is underdiagnosed. And there are some new guidelines put out regarding these, regarding the clinical criteria. If your patients have any of these associated conditions, illnesses, they may be more than likely to have protein-calorie malnutrition. Malnutrition can be in the context of an acute or chronic illness or malnutrition of social or environmental circumstances. So I put in here the clinical parameters, at least 2 of the following 6 characteristics. But more importantly, there's a website at the bottom that actually gives you a full chart that actually shows you, you know, how long they have to have it. Is it mild? Is it moderate? And so forth. So be careful. When we see weight loss and they're on, you know, replacement, you know, like Ensure, and you know, but and we don't actually see the diagnosis. We actually have to see, are they cachexic? Do they have protein-calorie malnutrition? All the weight loss and all those other things are just the meat for being able to code it. Now, I'm going to go through this section pretty quickly here. Hypertension, whether it's hypertension alone, 401.9 or 401.1 if it's benign, and then there's hypertensive heart, and then there's hypertensive renal, and then you can have hypertensive heart and renal, okay? The most important part here for risk adjustment is hypertensive heart is not an assumed relationship. So if you say that their congestive heart failure was caused by their hypertension or hypertensive, you know, CHF, we code 402. instead of 401. That's the first rubric. Hypertensive renal is assumed. We always code it as a combination code if we see the two together. And the most important thing with this, it's a 403 category. And the most important thing here is the stage of CKD. Very, very important. That's the driving factor for the risk. I can't emphasize that enough. The stage of ulcers, the stage of CKD has to be documented. We sometimes will just see a GFR factor, and we know that patient probably has, CKD, but we can't code from a factor alone. So make sure not only the GFR is supporting the diagnosis, make sure, and then the National Kidney Foundation actually has a nice chart that tells you, the criteria for CKD. Dialysis status, the status of dialysis, V4511. Or the noncompliance with dialysis, V4512. That's a status code that you would want to code at least once a year. Now, this is not the code for admission for dialysis, because there is a separate code for that. This just means my patient gets dialysis. Once a year, we put that on the claim. It actually has a pretty high value. And if you have hypertensive heart and renal, same rules apply. Hypertensive heart's not assumed. Hypertensive renal is assumed. And most importantly is what two codes do we code? Type of heart failure or heart disease and the stage of CKD. Now, the OMI was in the model, and they did take it out for 2014. Any arrhythmias that are listed here are important that you document within the medical record and let us know, are they on anticoagulation, and take special note of the final one, the SSS syndrome, the sick sinus syndrome. If there's a coding clinic that states if there is a pacemaker, we do not code it unless there's a problem with the condition or the monitor itself. So we want you to document it. We want you to continue what you're doing, because I see it quite frequently, SSS on pacemaker, but we don't code it. We code it as a pacemaker status. We do not code it as sick sinus syndrome. That's a little odd because we still code CHF that's compensated and so forth, but there is a coding clinic for this, and that's the rules, and we have to make sure that, clinically you want to document it, but we shouldn't be picking the code for it. So here are some of the common documentation things that we see. Diagnosis that are coded without the supported meat. Assessments not clear. Not giving us the manifestations of diabetes and making the causal relationship. Incorrect ICD-9 specificity, selecting the wrong codes. Encoding resolved conditions. I just did some education for a group of pediatrics, and that was a big one. They were coding a lot of resolved conditions. Status of cancers not being documented. Remember the status and the metastasis. Coding the current stroke in the outpatient setting. Fracture codes. Fracture codes are only coded since 2007 during the acute phase of the fracture, which is the first time you're seeing that patient, ER treatment or surgical treatment. After they come back for the follow-up, it's a V code for follow-up fracture care. Unconfirmed diagnosis, probable, suspected, coded, coding signs and symptoms, and lack of supportive documentation for chronic conditions and status codes, not bringing them forward every year. This is a list of what risk adjusts. Some of these are missing a digit because it depends on what tissue or organ was transplanted. But mainly an artificial limb, any amputations, including of the lower limb, including a toe, risk adjusts. So you have to say once a year that patient has an amputated toe. Seems a little odd, but that's how it works. Icd-10, which I think you're going to be excited to hear about.
So it's an increased number of codes compared to ICD. It's an increased specificity specificity of codes. Carol kind of touched upon this point. For instance, laterality. You're going to have to know if something is on the right side or on the left side. We don't need that for ICD-9, but for ICD-10, we're going to have to know that. Is it, a fracture of the right wrist or the left wrist? Is it weakness on the right side or the left side? It's a change in the number of characters per code, and we're going to go into this in a little bit more detail in another slide. And again, it's more specific. It captures the anatomic site, the cause, and the severity of the conditions. For instance, if something just happens, an acute fracture, and it's or a follow-up care for a fracture, we have to be very specific now with ICD-10. We won't really be able to fudge this like we may have in the past. In some ways, this might almost be better because you've all probably been frustrated like I have when you're trying to find a code that describes what you're actually taking care of the patient for, and you can't find it, and you end up using a nonspecific code. I think in the long run, ICD-10 is probably going to make it easier for us. So ICD-10 affects the clinical modification diagnosis codes and the hospital inpatient procedure codes. It does not affect the CPT codes or the durable medical equipment codes. It does not affect those. So some of the differences. We're going from 14,000 codes to 68,000 codes. I calculated this. I brought out my calculator last night. I just tried to figure out it's a factor of 4.8 times. So there's 4.8 times as many codes with ICD-10 as with ICD-9. And I thought, wouldn't it be great if we could just take our ICD-9 codes and multiply them by 4.8 and put down that as an ICD-10 code? But that would be too easy, and of course that would be very wrong, so we're not going to do that. Going from 3 to 5 digits to 3 to 7 alphanumeric characters, which means letters and numbers. With the procedure codes, you're going from 4,000 codes to 87,000 codes. That's a lot. You're going from 3 to 4 digits, again, to 7 alphanumeric characters. So with ICD-10, the first character, it should say character, is going to be alphabetical. It's going to be a letter. And the letter is roughly going to correspond to an organ system. For instance, endocrine is E. That's a nice one because E is E. But then I believe I is cardiovascular, and I don't know why I is cardiovascular, but it is. But the important thing to know is that the first character is going to be a letter, which is going to correspond to the category. The second character is going to be a number. And then the third through seventh characters can be alphabetical or numeric. So this is an example of a one-to-one relationship, which means there's one code in ICD-9 and it nicely maps to one code in ICD-10. So for myeloid leukemia acute that's in remission, you have a 205.01 in ICD-9, and that equals a C92.01 in ICD-10. That's nice and easy. It would be nice if they were all one-to-one, but they're not. Here's an example of one code in ICD-9 that has to be represented by two codes when we transition to ICD-10. And it's cystoplasma meningitis. And basically in ICD-9 you have the one code, but in ICD-10 you're going to have to code the meningitis, which is G02, and the organism, which is B39.5. Diabetes, again, E for endocrine. So diabetes with neuropathy, and don't write these down because you're going to have to get a code book anyway. But diabetes with neuropathy will be E11.40. Nephropathy will be E11.21. Retinopathy, E11.319. But if it's proliferative retinopathy, it's E11.359. If it's with macular edema, it's E11.351. I'm going to test you on this later, by the way. So you may have heard the term general equivalency mappings, and what exactly are those? Well, those were created by the CDC and CMS, and it's a reference mapping. Basically, it's a table full of numbers, and it's for use for databases. It's not something that I tried to use this once when I first heard about it. I looked up one of the GEMs, and I thought, wow, this is cool. I can look from one number to the other. And all it was just a table full of numbers. So don't even bother trying to use it. It's really more for the tech people and the database people. Now, when you're talking about going from ICD-9 to ICD-10, that's called a forward mapping. And if you start with an ICD-10 code and go back to an ICD-9, that's called a backward mapping. Now, again, you probably don't need to know this because this has to do with the GEMs and databases. But you're probably wondering, why would I ever go backwards? Well, remember that we're still running reports and population reports and center reports and everything. And there's going to be a little bit of a crossover in the time span for what's covered when. So there is going to be some need to go back and forth, maybe not so much in the office setting, but certainly in the payer settings. So this is really important. If you take nothing else home from my presentation today, take this home. You need to get a code book. And that's basically what the slide says. You need to get a code book when you're seeing patients in the office and you're coding the diagnoses. You're not going to be using the GEMs. You may find some online tools that are going to help you convert, but buyer beware. You know, the accuracy of the tool that you purchase, if you plug in one number and you get another, is really dependent upon how well that vendor mapped using these GEMs. Get yourself a good book and learn how to use it. And a lot of us are already doing that now with ICD-9. I'm sure you have ICD-9 diagnosis code books that you use, and it's going to be the same thing for ICD-10. Okay, planning. Remember what I said earlier about as long as you prepare, you'll survive this? Go through your office and think about every single time you use an ICD-9 code. And it's obvious, you know, the billing piece is obvious, but there may be other places too when you're doing prior auths. You may have to use ICD-9 codes, for instance. What staff are affected? So, for instance, your biller is obviously going to be affected. The providers will be affected. Is the medical assistant or LPM that's rooming the patients, taking vitals, going to be affected? Maybe not so much. But definitely, you know, your billing staff and your providers will be affected. What software is affected? If you have an electronic health record, that's going to be affected. Hopefully you've all gotten communications from your EHR companies telling you how they're preparing for ICD-10. If you've not heard anything from your EHR company about ICD-10, you better get on the phone and ask them. What vendors are affected? So are you using any consultants that help you with your billing or any special software tools to help you run reports, because those will be affected as well. What forms? So obviously your super bills. You're going to need new super bills if you're used to circling a diagnosis. But again, things like prior authorizations will be affected. So basically you want to walk through your whole office and say, gee, when do I use an ICD-9 and who uses it? And those are the people and the places where you have to worry about training about ICD-10. What contracts are affected? If you have any quality assurance contracts that depend upon diagnosis codes, then those are going to have to be looked at. And perhaps I spoke prematurely when I said, you know, take one message home and it's buying a code book. Here's the other message. Set aside some money. We don't know the impact. We're hoping that things are going to go smoothly. At one point, Medicare was saying they were just going to assume that things were going to work when ICD-10 codes were submitted to Medicare, so they weren't going to do a lot of formal testing. I don't know if they've changed their stance on that. I know the AMA is concerned about that stance, that they're not going to test. So you really want to make sure you start planning now and set aside some extra money so that you can operate. Worst case scenario, which, you know, hopefully won't occur, usually doesn't occur. Worst case scenario, you have no money coming in for 2 months because of ICD-10. You want to be able to run the office. Okay, so as far as ICD-10 implementation, you want to, if you have to install any new software or get any upgrades to existing software, you want to start getting that in place. And then you want to test it. You want to make sure it works. You want to train everybody that's going to be affected by ICD-10, both providers and staff. For those who have certified coders, it would be a good idea to check with the certifying body and see if there are any additional training requirements in order to maintain that certification once ICD-10 takes place. Update all your paperwork, forms, and contracts. Look to your specialty societies for this too. You know, we talk about the super bill. I'm a family physician, and I know our academy makes available to us a nice several-page list of codes that are most frequently used by family physicians, and many of the other specialty societies probably have something like that too. So they can be a good resource when it comes to training and diagnosis codes and super bills and most frequently used codes. Create a mapping for the codes that you use most frequently. So, for instance, if you're primary care like I am, your diabetic codes. Write down your controlled and uncontrolled and which complications, and look up the ICD-10 codes ahead of time to see which ones you're going to be using most frequently. Same thing with hypertension. For those who are specialists, again, you know, you're going to be using your specialty codes, and you want to make sure you map it out ahead of time so you become familiar with the ICD-10 codes. Now, it's important to realize that the effective date right now, and I believe it will stay the same, is going to be October 1st for the use of ICD-10. So any services that take place as of October 1st should be coded with ICD-10. If you're resubmitting any claims for services prior to October 1st, you want to make sure you continue to use the ICD-9 codes. And we've also included in your handout some websites that you can go to learn a little bit more about ICD-10.